At least 30% of antibiotic courses prescribed in the outpatient setting are unnecessary, and it's estimated that by the year 2050, the number of deaths resulting from antimicrobial resistance, or AMR, will escalate to 10 million each year. In order to minimize the spread of antimicrobial resistant bacteria and further problems caused by AMR, there needs to be a significant decrease in antibiotic use in wound care wherever possible.
So antimicrobial resistance is a huge challenge, and it's going to be the biggest challenge in healthcare probably for the next few decades.
The best thing that we can do for antimicrobial resistance is not use antibiotics.
As one of the world's leading specialists in wound management, we at Essity understand the significance of antimicrobial resistance, and especially the role that proper wound care can play in combating it. It's time to fight antimicrobial resistance with Wound Warriors, an antimicrobial stewardship campaign to promote the responsible use of antibiotics in wound care.
Essity offers a full range of products that help combat AMR in wound care. Essity stands strong against antimicrobial resistance with a wide range of brands for sanitation and infection prevention and management, including Leukoplast and Cutimed. Antimicrobial Stewardship from Essity.
Good morning, everyone, and a very warm welcome to all of you. Thank you so much for taking the time out of your day to join this webinar. And more especially, thank you to Essity for providing this platform to discuss this very relevant and important topic on antimicrobial resistance. So we are fortunate to have Sister Helen Loudon and Dr. George Smith, who will present on infection prevention and control measures, as well as look at some of the important intra-operative measures that have been put into place to reduce the risk of surgical site infection. But before we begin with our presentations, we'd like to run a poll. It consists of 3 questions, and I'd like to encourage you to participate. The purpose of the poll is just to gauge an understanding of our audience that's present with us today, as well as to look at ways we can ensure you have the most relevant experience with us for the next 2 hours. So the poll questions should appear on your screens, and we look forward to your responses. Thank you. Okay, so looking at the results, it's excellent to see so many different specialities present, which is exactly what we wanted. I think when we look at antimicrobial resistance and stewardship, we always talk about a collaborative approach and a multidisciplinary approach, and hopefully this is something we could strive for in our various areas of practice. The second thing I can see is that many of you are involved in stewardship, which is excellent, which means we'll have a good discussion at our Q&A session later on in the webinar. So this now brings me to the presentation part of the session. Thank you. To kick off the session, it is my privilege to introduce our first speaker, Sister Helen Loudon. Helen is an independent infection prevention and risk management nurse consultant with a specialist interest in the prevention of healthcare-associated infections, antimicrobial resistance, and wound biofilms. Until recently, she was the lecturer and facilitator for the short learning program in infection prevention and control for the University of the Free State, and is widely published and has co-authored a textbook for the new South African nursing curriculum. Helen serves on several advisory boards, including the KZN Specialist Network Antimicrobial Stewardship Subcommittee, the National Hand Hygiene Excellence Working Group, the SA Bureau of Standards, and the Wound Healing Association of South Africa. Her practice credo, protect your patients and empower your people, is the foundation of her service and mission to provide support on issues relating to patient safety, practice standards, and continuous quality improvement. I will now hand you over to Helen, who will present her topic titled Man, Microbe, and the Environment, Break the Chain. Over to you, Helen.
Michelle, thank you for the introduction. And to all of you taking part in our webinar, thank you so much for making time to join us on this topic. With the COVID-19 pandemic being up front and center for the last 18 months, there's been so much emphasis that I think we've been very quick to forget that multi-drug resistant organisms and antibiotic resistance is alive and well. So the timing of this webinar is particularly pertinent. Just before I go any further, just to mention that I am an independent practitioner, and I do receive speaker honoraria, and I'm very fortunate to participate on several quality management and advisory boards. However, if I do mention a product, please know that this is for illustrative purposes only, and it shouldn't be interpreted as an endorsement. Now, when we talk about the pillars of infection control, it all depends on the source that you look at. There will be several sources, but the concept is important, because the concept of pillars is that if your pillars are weak, your structure will collapse. So in this image here, I've got 5, but from my perspective, I'm going to be talking mainly around the non-negotiable factors that should be part of your infection control program. I'm not only talking here to those of you that are working in a hospital setting. Gone are the days where infection control was generic and we implemented a system right across all the disciplines and everybody did the same thing. Those days are long gone. What's important now is that infection control measures, no matter whether you're working in an ICU or an operating room or a long-term care environment or in the home, must be risk-based. That's critically important. Similarly, they should be discipline-based, because your pathogens will differ between the different medical disciplines. And your measures must comply with international and local legislation and proven best clinical practice. At the beginning of the pandemic, it was very exciting that we published our very first National Infection Prevention and Control Strategic Framework here in South Africa. And if you're not familiar with this document, I would strongly recommend that you take a look at it. Absolutely beautiful document. And since it was published, there's now a practical toolkit to help you implement your infection control measures. So I would encourage you to look at that. In order for a patient to develop infection, we do need to create somewhat of a perfect storm. So on the left-hand side of your screen here, you've got 3 intersecting circles. Firstly, you do need a sufficient microbial dose or concentration, in other words, of the pathogen involved. And that pathogen needs to have virulence capabilities. And by that, I mean produce biofilms or matrix metalloproteases or inflammatory cytokines, or have drug-resistant features. And then to be able to create this scenario where we have a healthcare-associated infection in our impaired patient host. On the right-hand side, obviously, here is your chain of infection as you all know it. And depending on the field in which you're practicing, it's very important that you get to know what are the reservoirs or the hidey holes in which the pathogens are hiding in your environment. And here, for example, everybody thinks about contaminated medical equipment, but consider water supplies and also consider your lotions, your antiseptics and your disinfectants. They are frequently a reservoir for microorganisms and cause infection in compromised patients. Then, of course, there must be a portal of exit, be that our hands or a dirty surface or contaminated equipment, and then the infection is spread via contact or airborne means to the patient where it gains entry. Possibly the biggest non-negotiable in an infection control framework is the Occupational Health and Safety Act. This piece of legislation underpins everything you and I do in our daily practice. So your practice must be compliant with the OSH Act, and two significant pieces of legislation that are contained within it. And these are the Hazardous Chemical Substances Act and the Hazardous Biological Agents Regulations. How do you combine all of this to have legally compliant care? You compile an Hba risk assessment. And this is a legal requirement for our practice and must be undertaken at least annually. Now, the hospitals are good about having Hba risk assessments simply because it is a requirement for their registration with the Department of Health and to get a practice number. However, did you know that if you're working in the community or you're in an old age home or a frail care facility, you also by law require an Hba risk assessment? I mentioned earlier that the organisms differ between disciplines, and this is why we no longer apply a one-size-fits-all across the board. So you'll have an Hba risk assessment, say for pediatrics, you'll have a completely different one for orthopedics, and you'd have a completely different one for wound care, as opposed to frail aged care, for example. If you are an employer, and by that you only need to employ one person, you must be able to demonstrate proof of annual PPE training. And that is very important that you know that. And your Hba risk assessment will mention what PPE is required in the delivery of your care. And then besides that, you will also need to be registered with the Compensation Commissioner to be able to report accidental exposures, such as blood splashes, needle sticks, and occupational allergies, such as glove or latex allergy, to the Compensation Commissioner, and for your employees to be able to benefit from the fund. Lastly, your Hba risk assessment will mention, when you talk about a specific organism, it will describe how that organism gets from point A to point B, in other words, its mode of transmission. It must specify whether you need to isolate the patient for that particular pathogen, what kind of hand hygiene is required, and what kind of PPE is required. And please note that you can get templates for Hba risk assessments on the internet. They are classified according to high and low risk, as you can see by my little example here. Please note that you may not remove notifiable conditions from your Hba risk assessment. So an example of a notifiable condition would be tuberculosis. You're thinking, well, that's not relevant to my practice. Because it is a notifiable condition, you still have to have it on your Hba risk assessment. And then last but not least, your risk assessment should make mention of antimicrobial stewardship, which Michelle is going to address, and the organisms that you're going to be screening for in your patients, so that you are aware of it. So please keep a note of the organisms that you are seeing on a daily basis. These 6 need no introduction. These are all bacteria. They are a mixture of gram-positive and gram-negative, but they are the most commonly implicated bacteria in our healthcare-associated infections. So again, in a hospital, they keep surveillance statistics of all the microorganisms. But if you're in the community, you need to as well, because it can alert you as to whether you are encountering cross-infection in your practice. Things have got so bad now that medical microbiologists have coined the phrase the escape CCC pathogens. Now, 5 years ago, we only talked about the escape pathogens. There was no CCC. But before we had Clostridium difficile was contained within the word escape. We spelt it with a CK. But now with the increased incidence of Candida albicans, Candida auris, and your carbapenem-resistant bacteria, we're now having to display these as a separate threat All right, so that's why we talk about the escape CCC organisms. So I would encourage you to read up on this threat because it is alive and well in South Africa, and you need to make sure that your infection control measures are addressing the modes of transmission and infection by these organisms. When we talk about hand hygiene and decontamination of our environment in which we deliver care, there are some more non-negotiables. As I've mentioned, your strategy will be guided by surveillance, not only of your patient risks, but also of the organisms and the infections that they are causing. When it comes to your antiseptics and disinfectants, you must use SAHPRA-registered products, please. Because of the pandemic, there have been some very, very suspect products that are now available on the market, and they do not meet international and local infection control specifications. Our South African Health Products Regulatory Authority, SAHPRA, tests antiseptics and disinfectants in independently accredited microbiology laboratories. So if someone wants to sell you a product, that's the first question you should ask: is your product registered with SAHPRA? And if they say no, then I would avoid them in general. The second question you need to ask is, can you see their independently accredited microbiology test results to see that the antiseptic or the disinfectant that they're trying to sell you is indeed effective against the pathogens that you are encountering in your daily practice. Disinfectants do not make dirt safe. I cannot emphasize that enough. You cannot disinfect anything unless it's been scrupulously cleaned first with a detergent. And one of the practices that we're now seeing with the pandemic is that hand sanitizer and chlorhexidine gluconate liquid hand wash is being routinely now to wash trolleys and surfaces and counters. Please, this is very lazy practice. The only exception to this rule would be, for example, in a commercial setting. Let's say you're at the pharmacy or at the bank, and they will now use a 70% alcohol hand sanitizer to wipe the counter in between you and the previous customer. That is perfectly acceptable because that counter is already clean. But remember, by the time the alcohol is evaporated, it has no residual killing benefit on pathogens on that surface. Lastly, there must be expert infection prevention and control involvement and oversight in catering and cleaning, laundry and waste contracts. Whether you're working in the community or in the hospital setting or in a frail aged home, it's very important that you get infection control advice to ensure that your strategies are appropriate for your level of risk. And sadly, you should be asking your contractual providers, do they comply with the relevant SAN standards and IPC guidelines? Unfortunately, this does come at a price, but there is nothing to stop you looking up the relevant SAN's quality standard, say for washing of linen or for the collection of medical waste. Medical waste, that's a poor example because that is legislated. Let's say catering or cleaning, and then you can independently implement those in your practice. So yes, just to go back to healthcare risk waste, this is legislated. So any medical waste supplier must comply with the legislation as well as the SAN standard. So that's me, and that is my time up. And I hope that I've given you something to think about. Thank you very much.
Our second speaker for today is Dr. George Smith, who will be presenting on infection prevention in surgical site infections. Dr. Smith completed his BSc and medical degree at St. George's Hospital in London before beginning his clinical career on the South Coast. He undertook his doctorate at the University of Hull, where he began his academic career. He was then successful in gaining a higher surgical rotation position and subsequent clinical lecturer post in general surgery with an interest in vascular surgery. Dr. Smith completed his training and gained fellowship at the Royal College of Surgeons of Edinburgh in 2016. He has since then undertaken clinical duties as a consultant at the Hull University Teaching Hospitals NHS Trust and Research as a senior lecturer at the Hull York Medical School. Dr. Smith's primary research focus is within surgical wounds and wound infection, primarily in undertaking basic science and clinical testing of new and existing dressing and infection prevention technologies. I will now hand you over to Dr. Smith.
So good morning. Thank you very much for the kind introduction. Thank you very much, obviously, to the organisers for the invitation to speak and clearly to everyone listening for doing so. So this talk is obviously about preventing surgical site infection, and it's a much bigger problem than most people imagine. So if you actually go and look in the literature for where the best possible follow-up has been done, that's usually in randomized controlled trials looking at SSI. So people often think their rates are quite low, but if you perform the same level of surveillance, if you go out and look for these infections, you're much more likely to find them. And certainly when people have done so, particularly in high-risk specialties such as vascular and in high-risk wounds such as cesareans, you can get rates up to 40%, which is really quite staggering. And these aren't, unimportant events. These are things that really affect patients and they really affect the healthcare systems. For patients, they have a really bad morbidity. Patients can come back with sepsis. Obviously, they suffer pain, potentially scarring. It increases the amount of time they're likely to spend in hospital. It increases the chances of needing to go back to theatre. And none of that is good for patients. For the healthcare professional and for the healthcare system, they do cost an awful lot of money. So we looked at some of our data for one of our trials, and it showed about £7,000 was the average cost for an SSI in vascular surgery. So that's about 140,000 rand. Now that's an average cost. So that ranges from a small bit of erythema on the skin that you can treat with 50, 60 rands worth of antibiotics, right the way up to a several months stay in intensive care that would cost tens of thousands of pounds. And indeed, one of our patients in our most recent study did spend over £20,000 on antibiotics alone. So that's not including any other aspect of their care, that's just antibiotics. So you're getting on for £500,000 just on antibiotics. That's a lot of money to be turfing out for something that is potentially preventable. And the other really big problem that we have that we'll hear more about later is this, that we are potentially looking at being returned to a pre-antibiotic era. Antibiotics are becoming obsolete. The more we use them and the more we have to use them, the less effective they are getting. So this is an old slide now, but its title says it all really. It's the perfect storm. So there are less and less companies researching antibiotics. There are less antibiotics being developed and actually approved, and there are more and more resistant strains coming through. And we do risk this real problem of leaving the world in a far worse state than we inherited it. Our children and grandchildren are going to pay the price for this. And really, it's on a scale very similar to climate change. We do need lots and lots of action, and we need it now. You can imagine what a single infectious agent without an effective treatment might do in terms of interrupting modern life and causing widespread death. And if you can't, just think back to the last 18 months. All sort of multi-drug resistant bacteria have the potential to do exactly the same thing. I did make this point recently, and a colleague basically said, well, COVID is a virus. If you think back to bubonic plague, that was the deadliest recorded pandemic in human history. Up to 60% of the affected populations died. 200 million people wiped out worldwide, and that was all bacterial. So a single infectious agent without effective treatment does pose a real threat to human society. On that happy note, one good thing did come out of COVID. It's been noted that actually lots of SSI rates reduced during COVID, and you can easily find papers about neurosurgery, sternal wounds, so very specific procedure types, but also much wider data. So the USA CDC national data set also supports a fall in SSI rates during the COVID pandemic. And there are obviously changes in practice that you might expect would have had an effect on that. We were doing less surgery, so maybe we see less surgical site infections, but actually in terms of percentages, that would be the reverse. So you're doing less surgery means that one surgical site infection causes a much higher percentage rise. And actually, despite that, we've still seen a fall. There were fewer elective procedures. So again, you might imply that the acute and emergency surgery will be more likely to get an SSI, and we've not seen that. So the rates would be expected to potentially go up, and actually they've come down. So how do we explain that? Well, it's very simple. Lots of people are washing their hands an awful lot more. We're all wearing PPE an awful lot more. We're cohorting patients an awful lot more. And these are really, really simple things that could very well explain why we've seen such a reduction in SSI. And it's those basics that you have to get right if you're going to get anywhere with preventing these. And prevention has always got to be better than cure for all the reasons we've mentioned in terms of antimicrobial resistance. So where do you start if you're trying to prevent SSI? So you could look at what factors actually could cause them or would increase your risk of them. This slide isn't meant to project well, it's meant to give a flavor of how many different things are interacting here. So some of these are modifiable, some are completely unmodifiable for different patients. So how do you decide which of these factors you're going to address? If you do a literature search, you'll probably find that there are tens of thousands of papers out there looking at SSI and accordingly addressing several of these factors. If you don't have time to read all of those, which I certainly don't, then SSI guidelines are really the place to go. Included here, I've put the National Institute of Clinical Excellence, NICE, here in the UK. There's a Wounds UK best practice statement. There's also the WHO guidance, and there is a European guidance that's slightly more recent than that. And they all really break this down into several stages, so preoperative, intraoperative, and post-operative phases. And they address lots of different aspects from the sort of factors that could increase your risk. And it makes sense that, you know, if you can only address one factor, you're only going to get the benefit of addressing one factor. If you can address lots of factors in what's now well known as care bundles, you get a marginal gain theory. So, you know, 0.5% here, 0.5% there soon adds up. If you can control the smoking status, the level of anemia, control diabetes, hypertension, make sure you minimize length of stay in hospital, all of those kind of things, that's going to give you a very little improvement, but lots of little improvements are as good as one big improvement here. So all the simple things we've already mentioned all count towards this. The quality of evidence around surgical site infection guidelines is slightly disappointing coming at it from a pure academic point of view. So the 30 recommendations from the WHO, none of them are based on what we'd consider high quality evidence. A third are only moderate quality, half or just over half are low or very low quality evidence, and 4 are based on, according to the WHO, no evidence at all, which sounds terrible, but actually some of the stuff we do in surgical site infection, as we've already mentioned, is so obvious you kind of don't need to do the trial. There's the classic example of an RCT, a randomized trial of jumping out of a plane with or without a parachute. Nobody's ever going to do that because we already know the results. It's going to be a lot of danger, and you know, it's something you wouldn't want to expose people to. So no one's going to do the don't wash your hands trial. But that doesn't mean we shouldn't be doing it because there's no evidence. It just means that the evidence either isn't practical to produce or it hasn't caught up yet. And again, all of those simple things will add up. The problem it presents is that lots of the recommendations don't have the same recommendation between documents. So you can see the WHO, CDC, and the 2 NICE documents that involve surgical site infection listed here, and they all highlight different aspects of care. I would sort of argue that although they're not consistent across all of these, and that relates, as I said, to the quality of evidence, it doesn't mean that you shouldn't be doing any of these that you can. It's all marginal gains, it's all care bundles. So any of these things that you can address, I certainly would say you should address for the benefit of your patients. And there's lots of them. So some of them will be easy to do, absolutely get on with them. Some of them will take a bit more work, do the work because it's worth it, but know that the evidence doesn't always back it up, mainly because the evidence is behind, I feel, in preventing all of these things. As an academic, I have spent time perusing evidence because I'm sad like that. So where are my top picks? What are the biggest bang for your buck things that you can do? So these are the 3 that I think the evidence really has caught up and where it's important to take these things on. So alcohol-based skin prep was certainly something that we do locally. There's lots of evidence for this. 30 studies were recorded in this meta-analysis by Chen et al., published last year. So that's over 29,000 patient episodes. And they showed across the board chlorhexidine was more effective at preventing SSI than povidone iodine. They didn't see a difference in skin reactions. The weakness in this paper, obviously, is that chlorhexidine is normally part of an alcohol solution and povidone iodine is normally an aqueous solution. To counter that, there is one study in cesarean sections which had both in alcohol, but still supported the effects of chlorhexidine. So that's not to say if you use povidone iodine, don't stop using it because you can't get hold of chlorhexidine. Do the obvious thing, do the best you can with what you have. If you can get chlorhexidine in alcohol, obviously there is evidence to support that use. What we've sometimes done actually is use chlorhexidine in alcohol and then use povidone iodine as well, just because there's no evidence for it. If it makes sense, do it. Other things you can look at, temperature regulations, normothermia. This is something we've really taken to heart locally. There's good randomized control evidence to say that you can reduce surgical site infection by maintaining normothermia during and certainly in the post-op period of any surgery. People have taken that slightly further. They've looked at, can you just warm the wound? Because obviously that would be easier. Now, the randomized controlled trial performed to date doesn't support a reduction in SSI with doing that. That doesn't mean if that's the only option that you shouldn't do it. It just means that it's not supported fully by the evidence, but surely warming is better than no warming. I certainly wash my wounds out with warm saline before I close them. Tissues exposed to the air in theatres usually get cold, and it makes no sense to close a cold wound. Interestingly, which I put in, which is slightly off tax, is a small RCT performed in 2019 or reported in 2019, which showed reduced skin necrosis with pre-warming of tissues. So actually what they did, they used hot water bottles, not that hot, only about 40 degrees, placed 3 times on a breast in this case, because that's where the surgery was taking place, but 12 hours before the surgery. So this was proposed to activate the heat shock proteins, and certainly they did seem to see some improved healing with this. So not a surgical site infection prevention method, but it did reduce skin necrosis. So I think that probably warrants further investigation from the point of view of an infection. Finally, the use of interactive dressings to manage and protect wounds. So all of the guidelines will recommend something along the lines of interactive dressings. Certainly the NICE guidance in the UK and the WHO international guidance both say you should use an appropriate interactive dressing. What they don't say is what an appropriate interactive dressing is. They don't define that in any sense. The European guidelines, the most recent ones, give you a slightly more helpful table of options and their associated evidence. And that they're kind of things that they've highlighted particularly are the silver impregnated dressings, closed incisional negative pressure, and a DAC or dialkyl carbamochloride coated dressing. So we'll call that DAC from now on for obvious reasons. So we looked at this, and this was a few years ago. From our point of view, we wondered, what's the most appropriate one of these for us? So we do use silver. We use it quite a lot in active infection. What we were aware of is there is data that suggests actually we can see quite high levels of silver resistance in some clinical strains when they're taken into the lab and tested against various levels of silver. And in one of those, the minimum inhibitory concentration, so the amount of silver it took to kill some bacteria after they developed resistance, was about 1,000 times higher than we'd expect in similar strains. So that's quite scary that we're seeing that level of resistance from silver. What we didn't want to do was add to that problem locally by using silver on all of our wounds, regardless of whether they're infected. So we've sort of held silver back for treating active infection. We didn't want to use it prophylactically for fear of that microbial resistance. We looked at the evidence for closed incisional negative pressure, and that's quite good evidence actually. So abdominal wounds, vascular groin wounds, and cesarean wounds, we all have meta-analysis, so multiple randomized trials all together suggest that actually this does have an effect on SSI prevention. They also seem to have an effect on seroma formation, dehiscence, hematoma, so they do seem to do good for wounds. The problem we had with this was trying to put that on everyone would very quickly exhaust all of our resources. In terms of cost, it's about 3,500 Rand for one of these dressings. And certainly on some of our vascular wounds that go right from the groin to below the knee, we might be using 2 or 3 of those. So that's 10,000 Rand for a dressing compared to what standard dressings cost in the region of sort of 40 or 50 Rand. So that wasn't really practical. We certainly use them on very, very high risk cases that we've identified in advance, some of the redos, for instance, but we can't afford to put that on every patient. And then we started thinking about what are the allergic and local side effects that we might see with dressings. So we started to investigate dialkyl carbamochloride or DAC. And this really interested us. What we found is obviously it binds by a hydrophobic reaction basically between the bacteria and the highly hydrophobic material that the dressing is covered with. Now, if the bacteria develops resistance to that, they would essentially be losing their binding mechanism that they use for binding not only to each other, but also to tissues. So any bacteria that develops resistance to this binding would actually be losing virulence. So they're very unlikely to be problematic because they can't bind to anything else. They can't form colonies, they can't form biofilm, and they can't necessarily infiltrate the wound. So that was very reassuring. You can see that actually the dressing won't really get saturated. So if you look at the electron scanning microscope picture here, bacteria are bound onto other bacteria, not necessarily directly onto the dressing. And that's in their nature, as we've said, they bind to each other using hydrophobic activity. So just because the hydrophobic surface is covered in other hydrophobic things, doesn't mean that hydrophobic things won't bind onto it. They'll bind on top of each other. And that's entirely non-selective. So we've got staph, we've got strep, we've got Klebsiella, we've got Proteus, all of those seen in this electron scanning microscope. The other thing is we did a systematic review before we put this onto any of our patients, because as we said, I'm an academic and I'm a bit of a pedant. So we found no evidence whatsoever of any systemic absorption. And we found no evidence in the literature of any side effects. And that includes use on postpartum women and also on children. So we were very reassured by that. What we did next was a very quick study. We took 100 patients who went through our operating theatre and we followed them up. And they're shown here in blue. So routine dressing patients in our standard practice had a look at 5 to 7 days, and then we looked again at 30 days. And what we found was at 5 to 7 days, we had 10 signs of SSI based on an asepsis score. So this is objective measures. And at day 30, we had 19. We then emptied the shelves of dressings in theatres and just put DAT-coated dressings there instead, and followed the next 100 patients through. And what we found was we only saw 1 SSI in the early 5 to 7 day period, and we saw 10 overall at 30 days. So that enthused us. That seemed, although it's non-randomized data, to confirm that this was actually doing something. And being interested in this, we then went and set up a small randomized controlled trial. So this was what we did. It's a feasibility trial, so it's not powered for full effect, but it was a single center randomized trial looking at 144 patients, and it was quite a strict protocol. So we randomized after wound closure. We didn't want any performance bias included. We had a 48-hour wound review by blinded assessment team. So what that meant was that the study team was in 2 halves. One half went onto the ward and removed all the dressings on the study patients, put them in an opaque disposal bag and got rid of them. And then the second team, who were completely blinded to what dressings went on, went round to assess the wounds. So again, another way to reduce bias. We assessed wounds with both the CDC criteria and asepsis score. And what we found was this. So at 30 days, overall SSI in the DAT-coated group, we had 16.2%, and in the standard group, we had 25.7%. So there was definitely a reduction there. And again, this is randomized data. So we've managed to get rid of all of those other confounding factors that might have influenced this. So overall, 16 versus roughly 26%. That's not significant. And as I said, this trial wasn't powered for significance. This was just powered to see, is it a feasible thing to do? And it certainly was. One of the real advantages to this is that you're not changing any major sort of structures. You're not putting in place anything that needs training. You're just changing what dressing you have on the shelf. The absolute risk reduction then is about 10%. So although it's not statistically significant, I would argue that's really clinically significant. Because if you get a standard dressing based on this data versus a DAT-coated dressing, your risk of surgical site infection is about 30% higher. And what you can do with that number is you can actually convert it into a number needed to treat. And that's this NNT at the bottom. What that means basically is that for every 10.5 patients you put this dressing on, you stand to prevent 1 surgical site infection. So if you look at that in terms of cost, this is ever so slightly more expensive than a standard dressing. You're probably talking about 100 Rand perhaps for a DAC dressing versus 50 for a standard. But if you put if you put 10 of those on, it's probably about a cost of 1,000 Rand. And we said, 145,000 Rand was the cost of an SSI. So this is very cost effective, and we have published that data. I'm not going to go into it in detail because that's not what we're talking about today. So the real key messages are antimicrobial resistance is a huge challenge for global healthcare and will continue to be so until things change dramatically. There is a paucity of evidence in some areas of SSI prevention, but the key thing to remember is that no evidence of an effect is not the same as evidence of no effect. So just because you haven't got a fantastic RCT that supports doing it, if it's going to reduce surgical site infection, either that you think it is or there's some low quality evidence that it does, it's worth doing because there's such a problem that it's the best thing you can do for your patient to try and prevent them. And as we mentioned above, we've seen it during COVID, SSA can be reduced. You just need to put that bit of effort in, and it's all about marginal gains, lots and lots of aspects to that care bundle. So that's all from me. Thank you very much for listening.
To round off this part of the session, I will be presenting on AMS implementation and its role in infection prevention. But before I start, please allow me to share some of my background with you. I currently work in a senior pharmacist capacity at a private hospital in Durban, and my qualifications include both a Bachelor of Medical Science degree and a Bachelor of Pharmacy, which I obtained from the University of KwaZulu-Natal. My passion for antimicrobial stewardship and clinical pharmacy steered me towards completing a clinical practice accreditation through the Nelson Mandela Metropolitan University, and I achieved my master's degree in clinical pharmacy in 2018 through the Sefako Magatu Health Sciences University, with a special focus on critical care in adult patients. I drove the antimicrobial stewardship program at a large private hospital facility in the Pretoria region for over 8 years. And during this period, I had the privilege of working closely together with all members of the multidisciplinary team, both at a ward and ICU level. So before I start, I wanted to mention that most of us have experienced at some point or the other in our careers stewardship fatigue. And I believe it's opportunities such as these and this webinar today that I'm hopeful will reignite and revive the fight within each of us to tackle this urgent issue of antimicrobial resistance. What also remains important is that it is up to us to ensure that the fundamental principles of both the antimicrobial stewardship and infection prevention programs are continuously enforced and reinforced at our places of work. Innovation within these programs become extremely important to ensure that the long-lasting effects of our efforts can be recognized. So I would like to start by painting the picture of just how worrying the current situation with resistance really is. So we all know that the antibiotic pipeline is running dry, that the development of new antibiotics is not something that we can solely rely on. So the two tables I've taken from the CDC website, and the table on the left looks at commonly prescribed antimicrobials and how soon after they release them to the market did we start seeing resistance developing. So if we look at a molecule like daptomycin, which is a fairly new drug and an excellent choice for skin and soft tissue infection, resistance had developed a year after the drug received FDA approval in 2003. A drug like zavicefta or ceftazidime avibactam, used to treat multi-drug resistant infections caused by gram-negative organisms, not currently registered in South Africa, but resistance developed in the same year that the drug was released, which means that in terms of its efficacy, it raises a question mark. If you look at the table on the right, organisms have been categorized by the level of threat they posed based on their prevalence. And there's even a watch list, almost as if these organisms are telling us to watch the space. There's several organisms under the urgent threats that we battle with in most of our facilities. And if we just key into wound care, for the purposes of today's webinar, having to treat and contain a deep-seated infection with an organism like Candida auris or a carbapenem-resistant enterococci becomes a daunting task in the absence of stringent infection and prevention control measures. So there's implications for our patients, and this is especially if we do not ensure that all our actions as healthcare professionals have some sort of accountability, and that if we don't work together to prevent the development and spread of resistant organisms, we end up with some of the serious issues that we see today. So, for example, a patient with a multi-drug resistant organism or a pan-drug resistant organism, there's limited treatment options, which means we resort to highly toxic combination therapies. And this means drugs, when used together, are potent enough to trigger off seizures in a patient or even cause severe and irreversible organ damage and even death. We resort to unregistered therapies, which becomes a costly exercise, and acquiring some of these drugs is a lengthy process, resulting in a patient having to pay from their own pockets. Prolonged hospital stay is inevitable with an overhaul of resources. And once easy to treat infections and routine surgical procedures now become extremely challenging. So we're seeing much higher doses of antibiotic surgical prophylaxis being used. If we look at our oncology patients and bone marrow transplants, or just patients being admitted to receive chemotherapy, all of them now are at extreme high risk of picking up drug-resistant infections whilst in hospital. So to be able to tackle these issues head on, it becomes imperative that within each of our facilities, we establish an AMS committee with a strong IP presence and ensure that they have a high level of involvement in these committees Each member will have a specific role and responsibility based on the areas of expertise. One of the key role plays is the doctor who's able to steer and lead that committee. It should ideally be someone that has a good knowledge of infectious diseases and antibiotics, or more favorable would be someone who understands the key principles of stewardship and is willing to drive the implementation of these projects within the hospital, as well as with his colleagues. The clinical pharmacist, in addition to having drug expertise, is an important liaison between nursing and doctors to ensure the success of all projects undertaken. Our infection prevention systems, in my experience, has some of the most biggest, or has the biggest task from all of us in ensuring that there's consistent and continuous adherence to all IP protocols. Any gaps or any breaks in the chain of events during a patient's hospital stay could have dire consequences for other patients and the hospital or facility at large. A consulting microbiologist is always an excellent resource to have, especially when they are difficult to treat infections or difficult prescribers that need guidance. Nursing management are important role players and largely influence the nursing component at board level. And if we expand this committee, and this means involving people from other disciplines, ensuring that there's involvement of other doctor specialities, this ensures our committee now becomes more robust. I've intentionally indicated that this is not a one-size-fits-all. Each hospital facility and facility is unique from a cultural, behavior, and organism perspective. The availability or lack of resources is also a large determining factor. But that being said, one should not wait for all the roles to be filled before commencing any sort of stewardship. Once your committee has been identified, it's important to do a situational analysis. And what this means is that as a committee, you're able to understand the challenges within the facility and start to put together a project plan which prioritizes the most pressing or urgent AMR issues or IP gaps. This project plan must be presented to all major stakeholders so further resources can be provided with urgency. The challenge with stewardship, and I'm sure you all agree, is that it requires a behavioral change on many levels. And this is a process that takes careful planning and effective collaboration. It becomes important to master the low-hanging fruit. I mentioned stewardship fatigue earlier on, where we continuously look at the dosing of drugs and the duration. We look at has cultures been done. We look at basic hand hygiene, and sometimes these become tiring to continuously enforce and reinforce. But that's exactly what stewardship is, right? We need to keep it simple and get back to basics. So things like hygiene posters, hand hygiene posters, training and regular awareness campaigns, ensuring all new staff receive basic AMS training as part of their onboarding becomes the important stuff. It's good to start simple projects that produce quick results, and this will strengthen the committee's intentions. And once these have been mastered, and once processes have been put into place to ensure continued adherence to appropriate prescribing and infection control, one could then tackle the more advanced stewardship principles. The committee will also choose to meet as regularly as possible or feasible to discuss new issues arising and the outcomes of projects undertaken. It becomes important that projects undertaken have measurable outcomes and findings that are shared, especially if it can be used to share best practice. It also motivates the team and work that they have been involved in receives the recognition it deserves. For me, what's missing in most of our hospitals and our primary healthcare facilities for people that are interested in getting involved is all of us have some sort of knowledge that we've developed over the years. Some of us are just starting off, but it's important that we ensure or allow for a new generation of people to continue and improve on what we've started. So mentorship becomes important, and it's crucial that we teach others and mentor as many people as we can to ensure that there's continuity of practice. I'd like to end off by saying that AMS and infection prevention are not two separate entities. And this is from my personal experience of working with stewardship and working with all the members of the multidisciplinary team. And I don't know if anyone's been reading lately, but in the light of COVID-19 pandemic, there's numerous articles emerging calling for the synergy between IP and AMS, which highlights that these are two very important roles that need to work together to reduce the further spread of resistance. So one can simply not function without the other. I would like to end by taking this opportunity to thank Essity for affording me the platform to speak about the importance of stewardship in infection prevention. And my hope is that we can all go back to the drawing board and ensure we are doing the following within our committees and in our individual capacities. The first thing is that our stewardship programs or initiatives encompass a holistic approach, and this means high-functioning AMS and IP programs. The second thing is that we are mastering the low-hanging fruit before tackling the more advanced elements of stewardship. And lastly, that we've all taken the time to mentor someone, either voluntarily or in our own work capacities. Thank you. Okay, so that brings us to the end of our presentations, and I'd like to thank both Sister Helen Loudon and Dr. George Smith for such in-depth discussions that and things that you've brought to our attention. And I hope for our audience, you're able to take some of these principles back and to your own areas of practice. We will now run a second poll just to see if our audience has a good understanding of some of the basic IP principles discussed, as well as some of the intraoperative measures we can take to reduce surgical site infection. I'd ask for you to please participate. Thank you. Okay, looks like everybody's been paying attention. So the first question was, what are the pillars of infection control? And the odd one out there was the social distancing aspect. And the second question was, what are some of the important clinical actions for the prevention of surgical site infection? And the answer was all of the above. So thank you for your participation. We will now proceed to the Q&A session. So I'd like to encourage you to please ask as many questions as you'd like. Obviously, given the time that we have, we'll assess the questions that come through. And then also, if you have any comments or suggestions, or you'd like to share your best practice with us, please feel free to do so. So we'll open up the Q&A session, and I see some questions have started to come through. So the first question was, if the correct surgical site infection prevention measures are applied in the perioperative period, why do some of the patients still develop a surgical site infection? If I can hand that question over to you, Dr. Smith.
Of course, thank you. It's a really good question. I think one of the slides in my talk obviously had lots and lots of different factors, and several of those are modifiable, and we can address those as part of a care bundle. Some of those are non-modifiable. So some patients who have been smokers for the last 40 years, who are obese, who are elderly and frail, those factors, no matter how good your care bundle is, you're never going to eliminate all of those. So particularly in vascular surgery, we have lots of people with poor blood supply, and the impact of all of those factors is what leads to an SSI rather than just the ones that we can address. So you can reduce the risk of SSI by addressing everything that is addressable. Sadly, you can't change the patient you're operating on. So there will always, regardless of how good your infection prevention and control is, you will always see some surgical site infections because of the nature of the intervention, sadly.
Michelle, could I add a couple of practical pointers to what Dr. Smith has mentioned?
Please do. Thanks, Helen.
Okay. What I would like to say is when we refer to the risk factors that make patients vulnerable to healthcare associated infections, we talk about endogenous risk factors. So those come with the patient themselves, and you've seen the many that George has listed on his slide. And then we talk about exogenous factors, and that's what comes from outside the patient, the environment and the healthcare service. On a practical level, I would just like to mention that diabetic patients have sluggish leukocytes, polymorphs and macrophages, and clinical studies have shown that these patients, when they're due to enter the second phase of healing, the inflammatory phase of healing, they're not able to mount an effective inflammatory phase of healing. And another very big risk that we're seeing clinically is patients that have been on long-term non-steroidal anti-inflammatory agents. And sadly, this is, I think, possibly one of the reasons why we're seeing a lot of orthopedic and joint patients succumbing to wound infection, you know, sort of 10 to 11 days post-operatively, because they too are unable to mount a good phase 2 of healing. And then the third one I'd like to mention, and this is for the nurses and the wound care practitioners in this group today, urinalysis remains very, very important for your patient. And given the all the things that we have to do nowadays and all the paperwork, this is something very important that tends to get missed. And it's almost like the CV of your patient. Please don't neglect to do a dipstick urinalysis on your patient, because very, very often a source of infection elsewhere in the patient's body can predispose that patient to wound infection. So, and this would include your surgical site infection. And then the other thing I would like to say in terms of endogenous risk factors, and something that I'm seeing in my practice because I have to assist with medico-legal cases, and that is the poor standard of post-discharge advice that patients are given when they leave hospital after a surgical procedure. Generally speaking, you know, an occlusive dressing will be put on in theatre, as George has mentioned, and provided there's no problems with exudate and leakage, the surgeon will instruct the nurses that this dressing is not to be tampered with until the patient comes back to see me for their post-op visit. What is important in terms of our patients that are high risk, for example, the ones that have been on non-steroidal inflammatory medication, cancer patients, patients with rheumatoid arthritis, diabetics, obese patients, these high-risk patients need to be informed that if they produce a lot of exudate post-operatively once they go home, bearing in mind that in the private sector, funders, as well as in the state sector, pressure on beds, patients are being discharged before the second phase of healing initiates, which is 3 to 5 days after surgery. And some of these patients, occlusive dressings will leak. And what is happening is they are packing these wounds on top of that polyurethane layer. The wounds are macerating and then they are dehiscing and breaking down. So I believe we should improve the quality of our post-discharge advice regarding exudate management in high-risk patients. Thanks, Michelle.
Thanks, Sister Helen. If I can go to the second question, what are some of the innovative initiatives that one could advise in terms of preventing the so-called stewardship fatigue, especially when it comes to the low-hanging fruit? I think that's my cue. So I don't really know if this was Albert Einstein, but and relating it back to stewardship fatigue, about the definition of insanity is doing something over and over again and expecting a different result. And similarly with the low-hanging fruit, basically for me, there's two scenarios. And the first one is if in your facility, you've implemented some sort of project or initiative that's working, right? And you're seeing these good measurable outcomes, you're seeing the data, things are working out really well, everyone's on board, then my suggestion is you stick to it, right? You don't tamper with that project or initiative. The important thing is that you ensure that any new member on the team, whether it's from a management level, whether it's at nursing, whether it involves the pharmacy, you must induct that new member on your project. They must be well aware of the intentions and the successes of that project. And this is to ensure continuity, right? The second thing is that even though your project might be successful, it's important that you still audit and feedback. So when people look at these, the data results and they look at the information that you're sharing, they're more likely to continue investing and keeping to those elements or initiatives that you put into place to ensure appropriate prescribing, for example. For me, the second scenario would be is if you've tried something over and over again and it's just not working out, you're not seeing the results you would like, okay? For me, unfortunately, the example here is surgical prophylaxis. So surgical prophylaxis is something that we've been battling with for years on end, and we're still not getting it right. And the big argument comes up is that, you know what, it's simple, it's single drug, it's one dose, why can't we get it right? And obviously the guidelines are readily available to everybody. They, you know, everyone has access to them. So it's evidence-based guidelines, so why can't we get it right? So using surgical prophylaxis as an example, you need to think about a multi-modal approach. So it's not it's not a single thing that's actually going to, where you're going to see results. So my advice specifically with surgical prophylaxis is getting that medical rep involved. She must set her table up, obviously COVID protocols, taking into account your COVID protocols at your facility, but setting up a table outside theatre, engaging with your doctors, your scrub sisters that walk in, engaging with the anaesthetist on the correct use of our surgical prophylaxis in our patients. The second thing would be to have training with your scrub sisters, because at the end of the day, they are the ones going to that cupboard, taking out that cefazolin 1 gram and handing it to the doctor that's going to administer it to a patient that's 120 kgs. But if you empower them, show them the guidelines, show them the data, and why you're suggesting that 2 gram or 3 gram dose, so that when the doctor requests the drug, they can have that sort of discussion with the doctor. Obviously not a lengthy discussion, given the fact that the patient's on the table, but I mean, have those sort of discussions. The third thing would be is to focus on your anesthetist, because often than not, and in my experience, when you call the surgeons to query a specific antibiotic dose, they will say, no, but it's the anesthetist, it's not my script. So to have a focused approach, with just having your anesthetist in one room or in a webinar where you address them, share the data, and not just international data, or, you know, it's got to be data that's specific to the facilities in which they work. And I think it hits home because you sort of show them, you know what, this is what we're doing. We're seeing an increase in our surgical site infections. This is what should be done, and this is the guidelines to support what I'm saying. So just to re-emphasize that it's actually it's a multimodal approach. There's no single cure for any of these sort of things. So good luck to all of you with these low-hanging fruit. Okay, moving on to the third question. How can we get IP and pharmacy to work more closely together? Helen, I don't know if you would like to also comment here before I do.
Yes, thank you, Michelle. You know, it's a multifaceted approach, and I believe, and I believe one of the basic faults in our clinical situation in our South African hospitals, it would appear in most hospitals that the infection prevention practitioner is not trained in and is not aware of wound care. It's not involved in wound care in any way. And I think that's a very big weakness in the system, because given our setup in both the state and the private sector, the chief pharmacist or the senior pharmacist very often have a say over the kind of wound dressings that are purchased for that institution and for the budget in that institution. And I believe that it should be a fundamental requirement for infection prevention practitioners to be trained and have an idea about wound care and the complications that ensure, because it's really when wounds go wrong, that's when you actually see the drug resistance and you see the pain and suffering that our patients and our families encounter. So in my practice, one of the first people and one of the first relationships that I would see to it that I built on when I was new in a hospital would be introducing myself to the pharmacists and indeed whoever was responsible for procurement or having an influence on procurement. And indeed, when I had a wound clinic, I would invite the pharmacist, the clinical pharmacist, to come and stick their head in behind the curtain and see what we were doing in the wound clinic, because this is the only way that people can see. And again, I used to find that this had a very positive effect on getting referrals from the surgeons for patients that had surgical site infection, so that they were referred for appropriate advanced wound management when the surgical site infection developed. Unfortunately, the reality is that our patients go and see their general practitioner, or they phone a neighbor or a friend who might be a nurse, and they say, my wound is not looking good, can you help? And then the fun begins, because you get all these remedies and suggestions, everybody means well, but the patient, and that George's very first slide about that below knee amputation, that is such a good illustrative slide, because by the time the patient is referred to a wound care practitioner, somebody who actually knows what's actually going on with this wound, and by then you've probably got drug-resistant organisms in there, etc., the patient has used all their resources, and there's very little left of the pie to be able to render good care. And that was why, just in the time that I had available in my presentation, was to encourage wound care practitioners and those that are outside of the hospital setting to keep a note of the organisms that they are seeing, and to speak to an infection preventionist or a medical microbiologist to get more information on these bugs. Because every microorganism tells a story. It has a past and it certainly has a future. And it's really very simple. This is why with Essity we have an initiative called Microbe of the Month, which tells practitioners where these bugs come from, what are the factors or the environment that they like to live in, and most importantly, what are the modes of transmission or the big yellow taxi that they like to catch to get from point to point B. So I believe, as I say, a fundamental weakness is that our infection preventionists are not involved in wound care in the hospital, and they should be making good relationships with the pharmacist and the surgical stores department.
Thanks, Helen. No, I agree with you. I think no one's going to hold us by the hand and introduce us to these important people. So it's actually our duty to go out there and collaborate effectively to ensure that our patients benefit from this sort of multidisciplinary approach we always talk about. But also from my experience, I think it's important that the IP and clinical pharmacist or ward pharmacists are introduced from day one, that you sit down as often as you can to discuss some of the challenges within the hospital. And I think each one needs to understand each one's intentions and what they would like to achieve within the individual capacities as infection prevention and then as clinical pharmacists. And often when we have these meetings, our AMS meetings, we have our pharmacy presenting on a specific drug that's being overutilized. And then further down the line, you have IP presenting on your hand hygiene bundles or some of the significant infections in the hospital. But I mean, if the two actually work together, and look, let's be honest, if a hospital has a clinical pharmacist, they're lucky. And then you have one infection prevention nurse at most. And some of these facilities are really big and the problems are also large. So I think it's important that they select maybe the top 3 most pressing issues within the hospital and work together to address those. I always think about UTIs, for example. So where the pharmacist would focus on the drug utilization in that specific unit. So for example, why are we using so much of phosphomycin, or why are we using so much of augmentin? And then you have IP ensuring for that project period, looking purely at hand hygiene. Are those urine samples being taken correctly? Is it a midstream? Is it the aseptic technique? Are the labs picking up that sample, timelessly? And then when this data is presented to our doctors, for example, it's more of a holistic approach, not necessarily segmented, where pharmacy presents again on utilization and then IP presents on their aspects. It's actually a collective data set that you have. And I think that's the only way. So hopefully everyone that's present takes this back and understands the importance that these two programs need to work together. And that's the pharmacy or the pharmacist and the infection prevention nurse. Okay, Dr. Smith, I think this question is going to come your way. Please, can you comment on the discontinuation of Suffoxitin and the effect it'll have on surgical prophylaxis and surgical site infection?
So it's not something we use regularly, actually. We've recently reviewed all of our surgical prophylaxis. We actually undertook quite a wide-ranging audit looking at patients, particularly for vascular groin wounds for our own department. We looked at all of the patients in the last year that we could easily identify that had microbiology results. And we've revamped our surgical prophylaxis based on what organisms we saw, which patients we tended to see which different organisms in. So we now have, I won't pretend that I'm a microbiologist and I have a decent understanding of exactly why the decisions were made, but we do now have different risk factors identified preoperatively, which do include diabetes and obesity as the main factors that we saw in that piece of work that led to driving slightly more aggressive surgical site infections. So we now have a different prophylaxis for a sort of what you might term a standard wound incision. And we also have a sort of an elevated prophylaxis for the more difficult wounds. We have had some issues in terms of penicillin resistance because we didn't build that in right at the very start, but that's now been covered as well. So we've introduced other agents for that. But I think it's about making sure you know your local microbiome, you know, what lives in your establishment, what lives on your surgeons, what lives on your patients. So the advice that we've got locally is not going to be transferable anywhere else. It's for our population in our facility. And I think that's a really important piece of work. So reliance on a single antibiotic is potentially likely to lead to trouble anyway, because you're using it in a sort of thoughtless blunderbuss type approach. You don't want to be giving a single antibiotic for everything that you do in every arena, because then every patient on that ward will have the same exposure, and any bugs that like to live in that ward have had the similar exposure as well. So I think specific antibiotics, you know, it's important to know what you need to use locally and what you need to use in particular procedures, particular areas of the patient. It gets down to that level. And the technology to do some more interesting things with this is rapidly coming to the fore now. We've got some work ongoing here, which I'm very excited about, looking at actual microbiomes according to patient age, according to how long they've been in hospital before their surgery, according to what prep we use. So we've got sort of DNA analysis of the whole microbiome of different areas of our patients, which will, I've drifted completely off the topic here, but I think that will be really informative in telling us just what's happening. Does actually, you know, making a surgical incision, does that change the microbiome that's around that area? None of this is known as yet. So that's going to be really exciting. But as I say, the basic clinical stuff, if you're not working closely with a wound healing lab that have got all the latest toys, is just look at your cultures, look what's growing locally, what's affecting your patients, and develop a local protocol. And that local is the key, because it's not going to be transferable even potentially across wards, let alone across buildings and hospital sites. Sorry, that was a very lengthy and very excitable answer about new technologies, but the overall thing is the same. It's got to be specific to your patients and where you are.
Thanks, Dr. Smith. I think you're referring to precision medicine, which we often forget, and that treatment should be individualized. So it's not a one size fits all. And if I can just comment on the Suffoxitin, I would assume you'd want some sort of anaerobe cover there. So clindamycin is still a good choice. It's got your gram-negative, positive, and anaerobe cover. Or you can go for a more narrow approach, which would be cephazolin plus metronidazole in place of that Suffoxitin, if I can also add to your response. The next question is, it's mentioned by AMS experts that organizational culture is essential to make change happen sustainably. You have given great advice on starting with the low-hanging fruit. Do you have any tips on how to sustain the development of AMS culture? Okay, so yeah, that's a tough job, I think, for everyone. And how do we ensure that we keep AMS consistent in our facilities and continuous? And that's where the innovation comes in. So you really need to have someone that's creative, someone that can think out of the box, someone that shares good relationships, not only with our doctors at the hospital, but with nursing, with pharmacy, with all the major stakeholders. And I think it's important to understand that you're working with different behaviors. It's behavioral change that we're dealing with, which is often very tricky and can be very challenging, especially when it comes to prescribing specifically. But I think keep it innovative, be creative. Like I said, think out of the box. The most important thing is don't take too much upon yourself, because there are other people that, they always talk about, looking through things with new lenses. Maybe have someone else that has that expertise in that specific area to take a look, to join your committee meetings, give their input. It's always good to have those additional people on board. We always forget about the microbiologists, your clinical training specialists, your IP must always be present at all these meetings. Get your unit managers from your ICUs involved, your unit managers from your medical wards involved, I think the more people on your AMS committee, the more likelihood or the more likely your committee is actually going to be successful. And any project that you want to implement, you'll have the buy-in from pharmacy, you'll have that buy-in from nursing, from your doctors, and you shouldn't have any issue going forward. So it is difficult, it is challenging, but like I said, just try and keep it fresh. Include as many people as you can. I don't know if anyone else would like to comment.
And Michelle, there's something I'd just like to add to what you've said. Going back to risk assessments, obviously this is a legal requirement for our practice for patient safety. And perhaps I should have mentioned that once each particular discipline or unit has done their risk assessment, this is put into a big pot and then combined for a hospital-wide risk assessment. And in my experience, there are certain hospitals that have a very good culture of safety. So we're not only talking about AMS here and infection control, we're talking about occupational health and safety incidents, slips and falls, medication errors, etc. So your unit risk assessment will also be making mention of these risks. And I found it helpful in the hospital-wide risk assessment, and obviously ownership of this goes to the hospital management, is then you can make sure that AMS and healthcare associated infection is then part of the hospital-wide risk assessment, so that all personnel are aware of this risk, because at the end of the day, AMS is also a lifestyle choice. It's not only to do with our patients and healthcare. It's antimicrobial resistance has this effect that goes out into the greater community, and because of air travel now, indeed the world, the globe. So I believe it should be part of the hospital management safety culture to make this part of the induction of all hospital personnel.
Thanks, Helen. There is one more question that's come through. I'm not too sure if we've covered it already, but I'll still ask the question. Do diabetic patients acquire infections quicker than non-diabetic patients post-op?
I don't know if George wants to have a word about this.
Yeah, it's difficult. The problem with certainly most surgical site infections is they're not always evident in the early phases. So diabetics, they do sometimes, depending on where your incision is, they do sometimes get slightly more aggressive surgical site infections, which relates to numerous factors, as Sister Helen has already elicited to some of those. But I think it's not that they develop them faster. As I say, they may be slightly more aggressive. And the real problem with surgical site infection as a whole is it tends to happen outside of hospital for the vast majority of cases, which is why the wound surveillance and that ability to get back to the surgical team or back into the wound care specialists is so important, that we've already spoken about. Making sure your patient knows who to call, and it's not the neighbour and it's not their distant cousin who once knew a nurse. It has to be someone who can give them sensible advice on the phone. And there are lots of electronic solutions coming out to this, such as wound care apps, automatically contacting patients at different intervals, and they can upload photos, they can put out messages, sort of cries for help if they're concerned. So there's lots that can be done to try and identify these. And I think that's one of the real weaknesses, certainly, that we have locally, is that we're not actively seeking infections to get to them sooner. So again, I've drifted completely off the topic, but yes. So I don't think diabetics necessarily present earlier, but they are sometimes more aggressive. I'm sure Sister Helen has something to add.
Yes, and that's what I would have said, George. And the other thing that I'd also like to make mention, and this goes again with what you've referred to as the microbiome, we do know that diabetic patients do become colonized with multi-drug resistant organisms. In other words, they're not ill, but they carry these organisms on their skin, in the oropharynx, and occasionally they have chronic urinary infections caused by carbapenem resistant or ESBL positive organisms. And that is why pre-colonization with a drug-resistant organism will substantially increase that patient's risk of a more virulent wound infection or complications post-operatively. Yes, and that's why they do need to be monitored beyond hospital discharge.
Okay, so thanks, Dr. Smith and Helen. So I don't see any further questions, so I'm going to ask, we've got one more poll to go through, it's the third one. It should show up on your screens. Can I please ask you to just respond to these two questions? It's to help us gauge how we can better plan for future webinars and basically what topics you'd like to hear more about, as well as the time of day that we're having the webinar. Thank you for your participation. And after that, I'll hand you over to Nodi Kama, who will address everybody. Thank you. Okay, are there any final comments from our speakers today, Dr. Smith, Sister Loudon?
No, I don't think so. Just a plea to everyone really to do everything they can. As we mentioned, low-hanging fruit, it's the simple things that often make the biggest difference. So just bearing in mind AMS and infection prevention is always better than cure.
Yeah, no, thanks. Just thanks so much for making the time in the middle of the day. And just to say, George, it's been lovely having you on board with us. Real privilege. Thank you.
Thank you.
Thank you.
Michelle, on your side, any comments before I wrap up?
No, Nodi, I just wanted to say Dr. Smith spoke about a perfect storm earlier on in his presentation. And I wanted to say, you know, the perfect remedy to that was all of us being together on one webinar presenting, you know, something that we all, something that we care about and have a lot of passion for, and that's our fight against antimicrobial resistance. And I think if we just sort of have this mindset and take it back to our areas of work and, you know, really put some effort into it, keep it fresh, you know, we really can make some sort of a difference. And even a small difference goes a long way. Thank you.
I agree 100%. On behalf of Essity, I'd like to thank our speakers this morning. And I would like to also just, you know, your dedication and your passion actually came through quite strongly during your individual presentation and the panel session. And obviously, going forward, it's continued education and the work that you do and the research work that you do. This is to all the three speakers. I would also like to thank everybody that has actually joined us this morning and was able to engage with us. I'd like to say, you know, the fight against infection as well as antimicrobial resistance requires a collective approach. And we hope to actually see you at our next session. You choose the topics, and I will actually be able to have an opportunity to evaluate your responses based on this, you know, the topics that we do have lined up. And the next session will be in the new year, and we really want to continue on this journey. And I would like to thank you once again and have a fantastic day. It's a wrap. Thank you very much. Take care. Bye-bye.